Welcome to the open forum of CMANA, broadcasted by CYC. I'm sure there isn't a home, a meeting, even a discussion on the phone that will not tackle a topic as confusing and becoming as controversial as COVID vaccines. Not just every day, but every hour, there are new information. First, I want to give you some estimates of where we are today. Globally, this is a very bad pandemic, and you see the numbers. There is over 1.6 million had died as of today. If you look at the numbers per country, and I have put as many countries as I imagine CYC is broadcasted to, you can see the affected numbers currently in all of these countries. All these red dots is the second wave. This map happened to be from yesterday's Johns Hopkins tracker or center. And you can see there is a lot of red dots all over the world. Please do not be deceived that there are some places in Africa do not have as big dots. That does not mean necessarily they don't have an infection. Unfortunately, it may actually mean more that they don't have enough ways to sample or to screen their affected subjects. Just in case if you think we are off the hook, unfortunately, COVID-19 hospitalization rate is increasing across the states. This map from CDC is showing you the weekly COVID-19, and you can see now we are approaching higher hospitalization rate as we were back in late March and early April. Some of us are under the notion or the myth that pandemic or COVID-19 affects only the older population. This is a publication came from, again, CDC on October 2nd, and there is a big shift toward younger age occurring in all US census regions, regardless of the changes in incidence during this period, and reflected in increased emergency room visits, positive PCR results, and confirmed COVID-19 cases. And those are the younger population, less than 24, between 16 and 24. All the audience, that please do not be deceived that the younger population are immune. Actually, this second wave is affecting the younger population as much, if not more. Look at the 18 to 29 years of age, and you can see how many are affected compared to what we were initially in the first wave. Again, if you think or you are under some notion that this is a political issue and nothing is happening, please believe us, there is a definite second wave. In New York, yesterday reported in New York 10,000 cases, new cases. In California is one of the worst badly hit states. Only yesterday reported 43,000 new cases just in one day on December 17. In Tennessee, close to 10,001 case in one day. Texas, 17,000 cases just on December 17. Florida, over 11,000 in one day. And in all the graphs, you can see that there was a dip during the summer, but unfortunately, we are catching up the second wave. Although this tracker does not include other countries, but for our Canadian audience who are with us now, there is also an increasing number in the Canadian provinces, and you can see from the Worldometer that there is an increasing number also in almost all Canadian provinces. Now I would like to shift the mic to Dr. Cecile Andraus. She is again our PhD microbiologist and immunologist from Virginia Commonwealth University, and now she is going to handle very important question. What is messenger RNA? How does it work? Why messenger RNA? Is it safe or not? So now I will ask Dr. Cecile to please go ahead and speak.
Good afternoon, everybody. I just would like to first thanks Dr. Hani Ashmalla for inviting me, and thank you for the nice introduction, and thank you also to Dr. Rafat Bishai for inviting me also to this forum. So first I would like to talk about the delivery system. What's a vaccine first? There is a slide before that, I believe. Yeah. Okay. Yeah, that's the first slide. Thank you. So how do vaccine work first? And a vaccine, basically, they mimic infections. So they stimulate our immune system to develop immunity to, specific diseases without getting basically the diseases. So they prime our immune system to effectively fight off an infection. Just a second here. Let me do this. Okay, to effectively fight off a later encounter with the bacteria or viruses. Next, please. So different types of vaccines against viruses. We have different types of vaccines. I just want to go over them, explain them a little bit. We first have the attenuated, also called live virus vaccine. These are made of complete virus particles, which lost the ability to replicate rapidly in their normal cells, as in smallpox and measles. Then we have the inactivated viral vaccines, and these are made of damaged viruses that cannot cause infection, as in polio vaccine. And also the Chinese, actually, COVID-19 vaccine is also an inactivated virus vaccine. The Chinese one is the one that actually Egypt will receive, I believe. The subunits or piece of virus protein vaccine, as in the case of hepatitis B or influenza vaccine. And then we have the newest one, messenger RNA vaccine, as in Pfizer and Moderna, COVID-19 vaccine. These were never used before in human. There are a couple of other vaccines. Actually, there is also a DNA vaccine, and there is also a viral vector vaccine. But because they were not approved yet, I did not include them on my slide. So how do the Pfizer and Moderna vaccine work? I'm going to concentrate on these two and talk a little bit about how do they work. But before I really talk about how do they work, I'd like to talk about, what's the messenger RNA and give you just a brief idea about what is it and where is it in the cell and what does it do and all that. So let me talk about the biology central dogma. You all heard, of course, about DNA. DNA is the genetic makeup of our cells. It has, all the genes in our cells. And the DNA it stands for deoxyribonucleic acid, and it's located in the nucleus inside the cell. I'm going to show you a diagram in just a second about that. So DNA basically has the information for all the proteins inside the cell. But in order to really make the protein, it goes through an intermediate compound first. So the DNA gets transcribed into what we call messenger RNA. Actually, it codes for different types of RNA, but I'm going to concentrate on the messenger RNA because the messenger RNA is the intermediate compound between the DNA and the protein. The DNA basically, again, has all the genetic information. It gives rise to the messenger RNA, not just one messenger RNA, but it gives rise to many different messenger RNA. And each messenger RNA is responsible for basically the production of one protein. It has the information to give rise to one specific polypeptide chain or protein. So the messenger RNA is a temporary compound because actually once it makes the protein, it gets degraded inside the cell. It gets degraded into nucleotides, the subunits of messenger RNA, and then the nucleotides get reused again and makes more RNA in general, or maybe more messenger RNA in particular. Next, please. So this is a diagram of the cell, and as you see in the cell is like orange in color, but you have this small circle inside, and that's the nucleus. The nucleus is where the DNA is present, and the nucleus and the DNA basically again gets transcribed into RNA, different types of RNA, like I said, and one of them is called the messenger RNA. And then the messenger RNA, it will basically get out of the cell, and ribosomes, something called ribosomes, they attach to the messenger RNA, and they start translating the messenger RNA into proteins. Okay, so from DNA you get the RNA, and from the RNA you make protein. The RNA actually stays inside the cytoplasm. Once it's, like I said, once it's translated, it gets degraded. It does not go back to the nucleus again. Okay. So once it gets out, it does its job and it gets degraded, and that's it. Next, please. Okay, so this is a figure of the famous coronavirus, COVID-19. And we've all seen this before, and we've all seen these spikes on the surface of the virus. And these spikes are actually proteins. And now you understand that each protein is coded for by a specific gene, basically, and this gene gives rise to a messenger RNA, and the messenger RNA makes the protein. So basically what they did is, first the Chinese actually, they sequenced the whole genome of the virus. The virus, by the way, is not considered a cell. It's not alive. We call it, like in case of live vaccine, we call it live, but it's not really alive. It's a particle. We call it a particle because it cannot replicate on its own. It can only replicate inside the cell, and it has its own genetic makeup. So once they found the sequence of the genetic makeup of the virus, and they published it in January 2020, and everybody, found out about that, then they basically, the researchers, they were able to determine the sequence of the protein spike, the gene basically that codes for the protein spike. And they were able to produce the messenger RNA sequence. They synthesized it. The messenger RNA sequence of a piece of the spike, not the whole protein spike, but just a piece of it. They synthesized it in the lab, and they put it inside a lipid nanoparticle capsule. And basically, this is the vaccine. Why did they put it inside a lipid nanoparticle? Because the RNA is very unstable. So you cannot just inject RNA into someone's, muscles or blood or whatever. It will get destroyed, right away. So it cannot survive. It's very, very sensitive. So, they had to put it inside something as a delivery mechanism to get inside of the cell. So the lipid nanoparticle is basically, lipid means fat. It's surrounding the messenger RNA to deliver it to the inside of the cell. Next, please. So this is a diagram showing basically, this is your virus. This is the virus, the coronavirus. And these are the spikes, the protein spikes on the surface of the virus. Yes. And once again, they found out about the sequence. They were able to synthesize the messenger RNA that codes for the, for the spike protein. They surrounded the messenger RNA with the nanoparticle, the lipid nanoparticle. And then basically this lipid, this is your vaccine. So then they injected it intramuscular, along, of course, with some salts and things like that. You're going to hear about them later on today. And basically, so these nanoparticles, they go and they attach to the cell. The cell actually engulfs them using a process called endocytosis. This nanoparticle gets inside of the cell, and the cell, once the nanoparticle is inside, the messenger RNA gets out of the particle, and once it gets out of the particle, it's going to get translated into the protein. And here you see, this is the cell, the human cell. This is the human cell now, and the human cell now has now the spike displayed on the surface of the cell. And once it's displayed on the surface of the cell, you have the immune system responding to this spike protein, and basically you have an immune response toward this spike in the form of antibodies and also T cells. I just want to tell you one more thing about this diagram here. It's not very accurate, because the size of the particle is not as, the same like the size of the cell here. The cell is much, much bigger than the particle. The cell is in the micrometer range, but the particle is in the nanometer range. So definitely this is much, much smaller. That's why it can get inside the cell, through this process that's called endocytosis. The cell is basically eating this small nanoparticle. This ends my presentation, and thank you very much.
Okay, thank you very much, Dr. Cecile. The next presentation about the vaccine components, sorry for the miswriting, Dr. Veronica Mawad, Fellow in Allergy and Clinical Immunology, Yale University.
Thank you so much for the invitation and for the introduction. So first, we'll start with talking about the Pfizer vaccine components. So now that you know what a vaccine is and what an mRNA vaccine is, we'll talk about each specific ingredient in the vaccine and how this compares to other common vaccines. So the Pfizer vaccine has several components. We have the mRNA, which is the only active ingredient. Then we have 5 lipids, and lipids are fats. Some of these are naturally occurring fats, such as cholesterol, and some are not naturally occurring. Polyethylene glycol, or PEG, is one of the lipids that are not naturally occurring, but is present in this vaccine. The fats are important because these protect the mRNA from being broken down by the body before reaching the cell. Next, we have several salts. So remember, it's very important to keep the proper pH of any solution once it enters our human body and once it enters the cells. So potassium chloride, this is a salt, monobasic potassium phosphate, sodium chloride, and dibasic sodium phosphate dihydrate. These are all different types of salts. Many of these are already present in our bodies. Sodium chloride is just your saline solution. Then lastly, there's sucrose. Sucrose is table sugar. This is to stabilize the vaccine in freezing temperatures. So those are all of the components in the Pfizer vaccine. Next, to talk about the Moderna vaccine, again, you have the mRNA, which is the active ingredient. Then the rest is very similar. It's the same concept. Lipids, again, very similar lipids, including cholesterol, as well as PEG, again, just similar to the Pfizer vaccine. You have something called tromethamine, which is actually a common medication given to stabilize water and electrolyte balance. It's used more in other countries rather than in the US, but this is a common medication. Tromethamine hydrochloride is just another formulation of the same. Then you have acetic acid, which is a stabilizer. It sounds kind of scary, but it's in vinegar and it's in many other foods. You have sodium acetate, which is another stabilizer. If you read the back of most of your foods, you'll also find it there. And then again, you have sucrose. So again, these are all of the components in the Moderna vaccine. So a note, compared to other vaccines, these vaccines do not contain what we call adjuvants. So adjuvants are used to increase or potentiate the immune response. Adjuvants such as alum, which is a derivative of aluminum, is present in many other vaccines. It's not necessarily bad. I'm just pointing out the differences. Alum is placed in other vaccines to increase our immune response. It is not present in the mRNA vaccines. There's also no formaldehyde. So formaldehyde is used to inactivate vaccines such as the flu vaccine, or the flu virus, I mean. It's used to inactivate viruses. Although it's mostly taken out of things like the flu vaccine, there could be small traces. There's no formaldehyde. There is no egg protein. Some vaccines, such as the flu shot, are derived from egg protein as well and incubated. There's no thimerosal, which is a preservative. There are no antibiotics. There's no polysorbate 80, which is an emulsifier, and which some people have reported allergy to specifically this component, which we call an excipient, as a component of several other vaccines, as well as IV solutions. So in general, these vaccines are relatively low risk for allergic reaction given few allergenic components. And this goes for both mRNA vaccines. So let's talk about allergic reactions, since we're hearing a lot about this. So allergic reactions can happen in response to anything foreign that enters our body. Almost all drugs, including vaccines, can cause an allergic reaction. We need to first define what an allergic reaction entails. There are different kinds of allergies. There is your most life-threatening, scary, type 1 IgE-mediated anaphylactic reaction that is, between 15 minutes and maximum of 1 hour after receiving a drug or a vaccine. That is the kind that we're all afraid of. That is an anaphylactic reaction. The percentage of people who have drug allergy in general is very low. Only about 1 to 2% of hospital admissions are for actual anaphylactic reactions. Again, just to reiterate, anaphylaxis does not occur a few hours or days after a certain drug or vaccine. It's within the first hour after receiving it. And every site is equipped to deal with immediate reactions. It's treated with epinephrine, as well as sometimes antihistamines and steroids. Also to keep in mind, there's a difference between allergy and intolerance. So you may have an intolerance to a certain drug or vaccine, such as stomach upset, nausea, vomiting, any other symptom. If it's an intolerance, remember that is very different from what we define as an allergy. So to address everything that's happening, of the now thousands of people who have received the Pfizer vaccine, only a few have reported serious allergic reactions. This is common to any drug or vaccine. This is not out of the ordinary. The only contraindication to receiving the COVID-19 vaccine is a prior history of anaphylaxis to another vaccine. That is currently the consensus in the field. So food allergy, medication, environmental allergy, all of those are not contraindications to receiving the vaccine.
Thank you very much. It was great. Our next speaker before we start answering questions is Dr. Nardin Mikhail, infectious disease specialist here in New York. She's an assistant clinical professor in Zucker School of Medicine, Hofstra University. Thank you for being here.
Thank you for the introduction. It's my pleasure to be here. We had met with CMANA in April, and we were discussing all the different problems of COVID and diagnosis and symptomatology. And it's very exciting for me that about 5 months later, or 6 months later, here we are starting to talk about vaccines. So that's very exciting, especially after the hundreds and hundreds of patients that we took care of the past 9 months. So I'm going to focus mostly on the Pfizer Biointact vaccine, which is also, and the study itself is called BNT162b2. The reason we're starting with this was the first one that was approved with emergency use authorization by the FDA. That was on December 10th. And their original article was published in New England Journal of Medicine in December 10th, showing the whole phase 3 clinical trial in details. So just to give you a brief idea how a phase 3 clinical study works, phase 1 and 2 involves very small number of people. Phase 3 involves tens of thousands of patients. So they started off with 44,820 participants. And the reason I'm showing this briefly is because if we look down the line, the numbers will shrink because of many factors. Either people get lost to follow-up, Either people, get withdrawn by the physician itself. Either people don't even meet the inclusion criteria anymore, and we will talk about who's excluded in a second. Or people will start getting the first dose and choose not to go to the second dose, or people fall out for other reasons. So going down quickly, we see that they started with 44,000 participants, and in the end, we actually reach about 37,000 participants, about 18,800 in one group, 18,800 and change in the other group. And this is what we call a double-blinded randomized controlled study. What does that mean? That those people are totally blinded. They don't know what they're receiving. A group will receive a placebo, which is not a real vaccine, not real medication, and a group will receive the vaccine, and they will follow them through. Next slide, please. So when we look at those people who received, the first dose of the vaccine, they were monitored along. And then the reason, again, I'm showing this is if we look at both ends of the placebo and the end of the vaccine, we will notice that one patient died on one end, one patient died on another end. And why is this very important? Because we need to remember that those patients throughout that period when they're getting monitored, things could happen, and we can't always link every cause effect together. A patient gets the dose and leaves and has a massive heart attack. Is that from the vaccine or just because they did happen to have a massive heart attack? So that's why it was very important looking at the people who dropped out from both groups to see that a lot of things happened in the placebo group that also happened in the vaccine group. At the end, we had the people who received the 2 doses with about, again, 18,000 and change on each group. What are the results on the vaccine briefly out of those 18,000 and change from each group? I underlined here that the results were a total of 170 cases of COVID 7 days after the second dose. So their primary endpoint was to look at patients who got the second dose of the vaccine, wait about a week, 7 days later, to see how many patients got COVID. So about 180 patients did get COVID. 162 were those assigned to the placebo, and only 8 cases were those assigned to the vaccine. And out of those, if we read further on, 10 of those 170 cases were severe COVID, and 9 of those severe COVIDs were in the placebo group, and only 1 was on the vaccine group, but the one within the vaccine group occurred actually between the first dose and the second dose, and not after the full 2-dose vaccine therapy. So if we look at the vaccine efficacy, which is the 2 main things that we are concerned about, safety and efficacy. So we look at those numbers with the 8 cases from the vaccine group versus 162 cases from the placebo group. That study proved that it's about 95% effective. And that efficacy was very equal across the border between different ages, between different sexes, races, ethnicity, obesity. Remember that those clinical studies weren't only done in one country, they were done at least over 4 different countries. And it's noteworthy to say that this study only started with people from ages 16 and up. So who are the ones who were excluded from the vaccine study? They're children. It did not include children, but currently it's noteworthy to say that they're having a new study of younger age group from ages 12 to 16 to try to see how they respond to the vaccine. Pregnant women were excluded from the study as well. They had pregnancy tests prior, but among the ones who got excluded along the way are women who were not pregnant and ended up being pregnant within the study. Another group that was excluded were the immunosuppressed population, people who are on chemotherapy or who are on immunosuppressive medications. They were also excluded from this study. HIV, hepatitis B, and hepatitis C, which are a big category of people, they were excluded in phase 1 and 2 of the clinical trials, but not in phase 3. They were actually included as long as their viral loads were stable and their immune status was stable. So in this graph, this is a very encouraging graph. It shows the placebo group is the top line in blue, and the vaccine group is the red line down below. And it basically shows that 95% efficacy we spoke about. Now, the vaccine is recommended in 2 doses, 3 weeks apart, 21 days. And like I said, the primary endpoint was checking 7 days after the second dose. That should be the peak of the immunization or the immunity to the virus itself. But this graph also shows us that around day 12, it started to show pretty much a good response. All right, so that's speaking of the efficacy. How about safety? Safety is a big concern of many, many people. So this graph shows us all the different side effects that were encountered by that vaccine. Most commonly, it was local reaction. And the reason for the local reaction is really what we call reactogenicity. It's basically your body's immune response responding to that vaccine. So most commonly, just local reaction, pain around the injection site, which is common with many other different vaccines. Some reported fatigue, headache, chills, some reported some body aches, and fever. But even the fever was in a smaller percentage, and it was more on the low-grade fever, although a few did encounter, but very minimal, did encounter a higher fever. Now, those side effects were noticed to be higher in the second dose of the vaccine, more so than the first dose of the vaccine. Less than 2% did have severe systemic reactions, and the severe included a higher fever, greater than 39 degrees Celsius, including going to a hospital, feeling a lot worse. But overall, statistically, if we look at all those side effects, they were actually worse than receiving a flu shot, but they were kind of better than the Shingrix vaccine, which is for zoster. About less than 1% of patients did have serious reactions, which included lymphadenopathy, which is swollen lymph node glands all over the body. Heart attack, again, wasn't a clear cause effect. Was it anything related to the vaccine, or was it like the heart attack that happened with the placebo group? That's still going on further studies. Some patients did have Bell's palsy, were reported as well. About 4 patients had Bell's palsy, which is paralysis of the 7th cranial nerve, but even that wasn't directly linked to the vaccine, and the percentage was less than the percentage of the normal population that would get Bell's palsy unrelated to a vaccine. Now, adverse effects, the companies themselves and the patients and the healthcare providers encourage anyone who have any severe adverse effect, obviously, to report to this VAERS, or Vaccine Adverse Event Reporting System, which is very important to track, because obviously any new medication, not just a vaccine, when given to 30,000 people in a study is very different than when given to 30 million people. Once it's widespread, we are expecting to see more side effects. So it's very important to report it to know more about it. Next, please. So quick comparison between the Pfizer Biointact vaccine and the Moderna vaccine. Now, the Moderna vaccine just had a hearing at the FDA Advisory Committee only 2-3 days ago on December 17th, and it just received its emergency use authorization by the FDA, and it's expected to start getting shipped over in the next day or so. Those two vaccines have more that are in common, way more than what's uncommon. So what's common between them? They're both messenger RNA vaccines. They're both approved to BioNTech. Pfizer is 16 and older, Moderna is 18 and older. So they're both still undergoing further studies for children. They're both very comparable in their efficacy. Pfizer is 95%, Moderna was about 94.1 or 0.5% roughly. They both involve 2 doses. The Pfizer was 21 days apart, 3 weeks apart, but Moderna was 4 weeks apart, so 28 days. Side effects, same thing, very comparable. It's all the local reaction of the arm pain, the fever, the headache, the fatigue, and again, they both more so after the second dose. What's really, really different between the two, it's not much so for the patients or the general population, but it has to do with the hospital, with the delivery, with the injection itself. The Pfizer involves a severely cold cryogenic storage tank. It needs negative 94 degrees Fahrenheit, which causes a problem in storage and delivery and distribution, makes it a little harder to reach smaller villages or other remote areas. Moderna, just a regular freezer works, negative 4 degrees Fahrenheit works. The other differences is Pfizer needs to be diluted, needs constitution of the vial, and the vial itself can give about 5 doses of the vaccine. And once it's diluted, it can stay outside for about 6 hours, not any longer than that. So it goes longer than that, it gets thrown away. Moderna vial doesn't need to be diluted, and it can give 10 doses on the vaccine. So it's really more so for nursing and for the people administering the vaccine, more so than the difference between the patients. Next, please. So briefly, Moderna results. Moderna only published the phase 1/2 preliminary data on New England Journal of Medicine back in November, but only in the most recent FDA hearing on December 17th that it did publish some data, which we'll go through here yet. So it's not yet fully published for us to read. But according to that FDA briefing documents that was released a few days ago, they said they basically enrolled 30,000 people, and 14 days after the second dose, and when they started to compare the numbers, as opposed to 7 days in Pfizer. 196 cases had symptomatic COVID after. 185 of those were in the placebo group, and about 11 were in the vaccine group. So the efficacy makes it 94.1%. What's also more, that Moderna presented additional data trying to show that the vaccine also appears to reduce asymptomatic infection by 2/3, which is very important as far as contagiousness epidemiologically, because the asymptomatic infections are the most contagious. People don't know they're sick, and they're going around spreading the disease itself. So there are other vaccines that we're not going to focus about much today, which are the AstraZeneca Oxford vaccine, which is completing their phase 3 study. I think we're more focused on messenger RNA vaccines currently and what's approved and what we have. There's a Johnson & Johnson vaccine that should be finishing up its clinical trials as well. And there are a lot of questions about the Chinese vaccines and the Russian vaccine, which again, we don't have much data for, and we couldn't find any published data for. But briefly from our research, there are 3 Chinese vaccines going on right now. One is the CanSino Biologics, which uses a whole different methodology with a human adenovirus as a vector to carry the protein, the spike protein, and that's the one that's used currently in Pakistan, Mexico, and Russia, with maybe some partnerships in Latin America. And again, I don't have any more data on it. I don't think there was any published. There's the one that's Sinopharm, which I think is the biggest one, that's using an inactivated virus. It's so far proposed that it's about 80% efficient, and that's the one that's totally endorsed by the United Arab Emirates, in Egypt, Jordan, Peru, and Argentina. Then the other one is the Sinovac or the CoronaVac, that's also an inactivated vaccine. As far as the Russian vaccine, again, no data was really published, but it's again using an adenovirus as a vector. Next, please. So last thing I just wanted to talk about with vaccine hesitancy. I don't know if I would want to categorize vaccine hesitancy as part of the anti-vaxxers who would not totally take vaccines. A lot of people with those current vaccines, because it is a new vaccine that's coming out, they're very hesitant to take it. They're not against it, but they might want to wait a little bit just to see what's happening before they start taking the vaccine. And this hesitancy isn't really a new concept. It was interesting to see that in the 1700s, at the time of smallpox, when smallpox was killing millions of people, Dr. Jenner is the one who started the whole smallpox vaccine, and he got it from the virus of a real cow. It was called a cowpox vaccine. And at that time, all these cartoons, like the picture on the left, came out that the people who were very hesitant, they started drawing cartoons of people growing cows on their bodies or starting to have horns because they were very reluctant to take the vaccine. And once they did, years later, smallpox was totally eradicated, and it's nothing that we even hear about these days. The other one, interestingly, was polio. When the Salk vaccine came out in the 1950s, and polio was killing and many people, especially younger children. A lot of the older people were very scared to take the vaccine, and there was a lot of hesitancy then until people were more educated and more encouraged when they started seeing some people and even celebrities there take the vaccine. So with that, I'm gonna turn it back to Dr. Haney.